Hi everyone, another episode, another things to discuss with. Uh, Today we are going to talk about acute ischemic heart diseases. So we have lots of problems in heart, and I hope that these are just medical and surgical issues. Okay, so acute ischemic heart disease is or shall we say, it's an ACS, formerly called as ischemic heart disease. It refers to a large spectrum of clinical conditions, including unstable angina, myocardial injury, and myocardial infarction. ACS is caused by a sudden onset of cardiac tissue ischemia secondary to impaired blood flow. It's a group of related syndromes due to imbalance between myocardial oxygen demand and supply from coronary arteries. So, ischemic heart disease is a condition for recurring chest pain or discomfort that occurs when a part of heart does not receive enough blood. So, if that happens, it results into oxygen insufficiency or hypoxia and anoxia, inadequate nutrient supply, and diminished metabolite removal. So ACS are caused by atherosclerosis, which takes into your coronary arteries often de- decades before a cardiac event. So it's a formation of atherosclerotic plaque begins with a low-grade inflammation in the inner layer of blood vessels. So the endothelial cells lining blood vessels sustain injury. It's a change in shape become increasingly permeable to fluid, lipids, and white blood cells. So we have there are types of ACS. Unstable angina. This may be a new symptom or can happen if you have stable angina that changes to unstable angina. So it may start to having angina more often when you are resting, or it may be worsen or last longer. We have also STMI. So ST segment elevation myocardial infarction is a type of heart attack that causes a sudden blockage of the blood supply to your heart. Non-STMI or non-ST segment elevation myocardial infarction is another type of heart attack or MI that does not cause major changes on your ECG, but a blood test will show that there is a damage to your heart muscle. So, what are the risk factors for having ACS or formerly called ischemic heart disease? Number one, these are just predisposing. Mostly, they're common in male smoking, hyperlipidemia, family obesity, high cholesterol levels, sedentary lifestyle, diabetes, physical inactivity, poor nutritional practice, and family history. So the clinical manifestations for these um, illness is the symptoms would be it collapse and sweating and pallor, your brain, chest pain, dyspnea, and nausea, vomiting. The signs that your patient will manifest. Usually they are pale, clammy, pulmonary edema, hypotensive, and arrhythmia. Usually their BP is 90 over 60 mmHg. So I have prepared here a very simple pathophysiology. So it occurs with your decreased coronary blood flow, then increased myocardial demand, then it diminished oxygenation. When it diminished oxygenation, well, the carrying capacity also diminished. So why does it occur? It decreased coronary blood flow. Naturally, it causes number one is atherosclerosis, vasospasm, and thrombosis. So uncommon are the causes are arteritis, so increased myocardial demand, uh, the symptoms for that would be tachycardia and hypertrophy. Then, when it diminished oxygenation, pneumonia and congestive heart failure can be manifested by your patient. So, diminishing oxygen carrying capacity to the blood will result probably with anemia or carbon monoxide poisoning. So, okay, not all of the process really come towards on that kind of problem. So this is the pathophysiology of ACS. It usually triggers by the rupture of atherosclerotic plaque in the wall and coronary artery. It causes activation, adhesion, and aggregation of platelets and clotting systems. As you can see in the diagram, there are really atherosclerotic plaque. So SCMI changes in ACS, acute coronary syndrome, STMI segment elevation, myocardial infarction. So as if you can see the tracing in your ECG, you will see that the ST is elevated. ST segment are elevated. So that's ischemia. The infarction is no STMI. No? So there are three arteries that has been that will be distracted in this problem. The left anterior descending or the LAD or the LAD, left circumflex, the LCX, and the right coronary artery or RCA. So what is the pathophysiology for this? Of course, I have said a while ago, usually it's for from males, family history of ischemic heart disease, and smoking, obesity, hypertension, dyslipidemia, and poor diet. So if these risk factors are manifested by your patient, so most probably there will be an inflammation in coronary arteries. Then there will be atherosclerotic coronary artery ischemic discomfort. It can be seen through your ECG, normal ECG, no symptoms at rest, angina pectoris. Now, after that, plaque erosion leading to rupture. So when it leads to rupture, atherothrombosis leads to artery occlusion and ischemia. That becomes your acute coronary syndrome. Usually, it has chest pain or associated with symptoms. ECG can be helped to detect. So, diagnostic criteria meets diagnostic criteria SDMI. So, if does not meet any of it, biochemical marker tests. So, what are these? Um, Diagnostic criteria for this are considered as unstable angina if you're using for biochemical markers tests. But if there will be an SDMI um, manifested to your ECG, it's usually a myocardial infarction. So both of them are myocardial infarction. However, uh, there will be differences between the markers or the diagnostic test that they have been using. So SDMI use ECG, non-SDMI usually use biochemical marker tests. So if you're wondering what is really the best for to know if your patient is under myocardial infarction, do the ECG. And then if still there will be problems, it means that's unstable angina. Then follow up with your biochemical marker tests. So critical stenosis, fixed stenosis, and collateral perfusion. These are the terms that you should know. Um, Critical stenosis are artery that is more than 70% occluded. So this is the diagram. So that's considered a stable angina. When we are going to talk about fixed stenosis, artery is more than 90% occluded. So that's unstable angina. Collateral perfusion, this means that if lesion progressively occludes at slow rate over a long period of time, that that is shown in this diagram, protective against MI. So what are the assessment that we need to know in doing or taking care with this ACS? So if you want to see, just look at the presentation. Okay. In nursing assessment for the ACS, it begins usually with the description of the presenting symptom. So if you're going to be a nurse that you're suspecting that your patient is under MI, you have to know what are the symptoms, the history, the illness, and particularly what heart disease they have been through. The history should include information about the patient's risk factor. Is there any chest pain or discomfort, difficulty in breathing, palpitations, syncope syncope or diaphoresis? So another one is a combination of symptoms. It includes chest pain, shortness of breathing, and indigestion, nausea, and anxiety. Patients have cool, pale, moist skin, heart rate, and respiratory rate may be faster than normal. So you have to remember for this that Socrates, site of pain, onset of pain, character of pain, any radiation, associated factors, timing of the pain, exacerbation or elevating factors, for example, the position of inspiration, and the severity of the pain using rating scale of 1 to 10, 10 being the worst and 1 would be the least. Processing in heart rate and rhythm, assess heart sounds, measure blood pressure to determine response to pain and treatment, and assess peripheral pulses. You should also evaluate skin color and temperature, auscultate lung fields, assess bowel motility, observe urinary output, check for edema, examine IV lines and sites frequently. So these are the things that you need to uh, anticipate. Blood tests would be LDL, HDL, total cholesterol level, and triglycerides. Next would be you should have ECG. Next would be you need to have coronary angiogram if it really suspected in your ECG, echocardiogram, myocardial perfusion imaging, and stress tests. So you cannot have that, all those things, if you don't have doctor's order. Okay. So you need to have good health assessment in order for your doctor to undergo all those assessments, diagnostic assessments. So in taking care of this, the nursing diagnosis that you can or you may use is ineffective cardiac tissue perfusion, related to reduced coronary blood flow, risk for imbalanced fluid volume, risk for infected peripheral tissue perfusion, related to decreased cardiac output, death, anxiety, deficient. So it's not really that particular, but the three things that you need to remember is ineffective cardiac tissue perfusion and ineffective peripheral tissue perfusion. So what are the elements contributing to develop this ischemic heart disease? Number one is inflammation. Number two is thrombosis associated with ruptured plaque. And number three, vasoconstriction. So circulating adrenergic agonist locally release platelet contents. So imbalance between endothelial cell and contracting factors. So mediated release from pervasive inflammatory cells. So what are the plans? So the immediate goals for treatment is to relieve pain and distress, improve blood flow, restore heart function as quickly as best as possible. However, if you are going to that's uh for emergency cases, you cannot really relieve the pain because you really need to assess. However, that's our goal. Okay? So reduce myocardial damage, maintain myocardial function. That is why you have to be fast. So in medical surgical management, we have thrombolytics, no, or fibrinolytic therapy. This is a primary PCI that is not available or transport time to PCI cable hospital. So this is via IV. We also have PCI, percutaneous coronary intervention. So this is a coronary angiography that injects dye into the arteries and used in primary PCI to determine where the artery is blocked. So we also have cabbage, no? That's what you call cabbage. Coronary artery bypass graft. This surgery bypasses the blocked arteries by using the graft of another blood vessels, usually from your arm or leg, to restore blood flow to the heart. Supplemental oxygen, aspirin, nitroglycerin, morphine should be given to the patient with suspected MI, along with the bed rest. The medicine of choice for pain and anxiety relief is morphine. So continuous cardiac monitoring is recommended after PCI or thrombolytic therapies, ideally in cardiac critical care unit. So aspirin beta blockers and angiotensin converting enzyme or your ACE inhibitor are also used as part of ongoing pharmacologic management. Aggressive rehabilitation program is started when the patient with an MI has stabilized. So do not take more, you know, it's a process. Nitrates or nitroglycerin patches, anticoagulants, analgesics, or morphine sulfate, angiotensin converting enzyme or ACE inhibitors, beta blocker initially and prescription continued use after hospital discharge, and thrombolytics are the pharmacological management that we may use during ACS or MI. So in relieving the pain, to help the symptom relief, use oxygen conjunction with therapy. So automatically, if you are suspecting with the patient to having an MI, put some nasal cannula, attach with ECG, cardiac monitor, then put some nitrates or nitroglycerin patch. You can really help to stop or relieve the pain. Okay, these are complementary alternative medicines. However, I'm not gonna discuss it well. It's more like another one or alternative one. So your diet for this, it should be it's an omega-3 fatty acid. So you have to avoid saturated fats, cholesterol. We also need to increase consumption of fiber-rich whole plant meals, and soy and other legumes are consumed. So any action that causes chest discomfort, acute dyspnea, or everything should be avoided if your patient has already history about this. Avoid walking against the wind and extremes of heat and cold. So they quit smoking, using tobacco, develop heart healthy eating habits such as avoiding large meals and eating quickly. Mm. And there should be an adjustment with the fit of therapeutic lifestyle changes and other diets have been prescribed. And we also need to check for the blood glucose and blood pressure always. Okay. So if you had an acute coronary syndrome, at the range of transportation and head straight to the nearest hospital. So thank you so much for listening for this topic. I hope you have learned something because we are going to jump another another topic. So remember, if your patient is under MI, you have to be fast. Okay, what is be fast? Actually, it's a mnemonics because being fast is always in MI. It just took you 6 to 10 seconds to help a patient suffering with MI, regardless of its unstable or stable angina. As long that you can really manage immediately, because the heart if you could really see or imagine the heart inside the inside the body of your patient, you will really see that there is really what do you call that one? There is really crumping, or also you have to notice and observe what kind of pain that they are having. Is it like stabbing? Is it like stomping? Or is it like you have been stomped by an elephant? Anything that would describe the pain will really help you to know that your patient is really in MI or ACS. Another way to know that your patient is under MI is there will be a left side weakness. Left side weakness. It's a sudden weakness wherein your patient will tell you, I can't move my left arm, I can't move my left clavicular area or my shoulder blades. It also radiates posteriorly towards anterior of your heart. So it could also mean that your patient is under ACS. Now, another one is if your patient always go to the bathroom and tells you that he or she is having diarrhea, and you know that your patient is already hypertensive. So you have to be careful. Now, I'm not saying that all of those patients telling you that they have diarrhea, stomach pain, or abdominal pain, automatically your patient is under MI. However, you have to notice and observe if it really lasts, because the time span would be seconds, no? 5 to 10 seconds, 10 to 15 seconds, that could also lead to another problem, because the goal of it is to relieve the pain and not to distract further. Okay, I hope another problem of we have here is heart failure. So heart failure is very common. I hope your heart are good. I hope everybody is in a good heart. No? So, what is heart failure? Heart failure makes it sound like there's no longer working at all. But heart failure is a chronic progressive condition in which heart muscles are unable to pump enough blood to meet the body's need for blood and oxygen. Basically, this heart can keep up with workout. So most likely your heart is fluid surrounding your lungs, swollen cyanotic. So you can see these are the clinical manifestation of your patient. If your patient is edematous and he's really trying to say that he can't breathe, he can barely breathe, it could be it's an enlarged heart. So signs and symptoms would be, of course, the SOB or troubling breathing, feeling tired, swelling in your ankles, need to urinate while resting at night, dizziness, rapid or irregular heartbeats, and dry hacking cough. So complications, abnormal heart rhythm, heart valve problems, kidney damage, anemia, liver damage, lung problems, extreme weight loss, and muscle loss. So how to prevent the complications? Severe heart failure can be life threatening. So these treatments, weight loss, a healthy diet, exercise, medicines can protect, but you keep your patient should be healthy and follow advice stick with the treatment plan. So what are the major risk factors? Increasing age, male again, hereditary. ECG is very important in diagnostic tests for heart failures. Ambulatory ECG or Holter monitoring, chest X-ray, echocardiogram, cardiogram rather, echo, cardio, computed tomography or is CCT, and exercise stress test, volume stress test or MPI or MUGA. So we have predisposing factor, which is your an age, hereditary, and gender. So if your patient has problem history of asthma, diet with high intake of sodium, smoking, alcohol drinking, and of course patients with having COPD. So there will be an inclusion of blood viscosity. If there will be peripheral or ventricular, there will be a problem with vascular resistance and workload. No, both of the ways. So we have to know the afterload for the peripheral and the ventricular. So when you do your ventricular workload or increase of left ventricular workload, there will be a ventricular dilation. So increase of carbon dioxide and increase of wall stress. If there will be an increase of wall stress, there will be hyperplasia. If there will be hyperplasia, remodeling will be increasing and that becomes increasing of auto requirements. It's just the same with increasing of CO2. No, it requires with O2. That is why if your patient is having heart failure, you may also conduct oxygenation therapy by doing nasal cannula. And chest x-ray is very important also in order for us to know if there will be a cardiomegaly or enlargement of heart. Prompts kidney. So in the peripheral vascular resistance, you may also think that there will be a decrease of blood flow to the kidneys and prompts kidneys to secrete renin that causes angiotensin increasement and angiotensinogen from your liver. So from this, again, I have said there will be an O2 via nasal cannula, decrease of contractility, and low O2. So there will be sympathetic activation, increase of forcing rate of contractation, and converting enzyme to lungs. So it could may also increase cell death, then decrease of ventricular contraction, and it may also lead to amount of blood in left ventricle. So by this, you may also give digoxin. Okay. Now, if we go back to another one or this one area, the vasoconstriction because of the angiotensin 2. If angiotensin 2 increase, there will be aldosterone release. So there will be an increase of tubular sodium reabsorption. So what happens to your patient? The osmotic fluid reabsorbs and the water conservation. So atrial dilation, remodeling, sympathetic activation, increase of left atrial pressure, inability to receive full pulmonary blood, and pulmonary pressure. So going back, so the left manifestation of your heart failure, SOB, respiratory rate of 23, productive cough, stridor, crackles, pale extremities, body weakness, and exhausted facet. For the right manifestation or right side heart failure, bipedal edema, descended jugular neck veins at 45-degree position, and anorexia. So if your patient is in the right side manifestation, you should have lactulose and Dopulac or whey protein. So when I have said a while ago, what is the right heart failure and left side failure? So again, what is a right side failure? It occurs with the right side of your heart can perform its job effectively. In our right side, we usually think about the heart failure. Systolic heart failure occurs when the heart muscles loses its ability to contract. While in the sided heart failure, left-sided heart failure occurs when its left ventricle doesn't pump efficiently. Then diagnostic heart failure also is a failure when the heart muscle becomes stiffer than normal. Left-sided failure. So as you can see with the faces here, the right-sided failure. So what are the nursing diagnoses? Activity intolerance, excess fluid volume related to heart failure syndrome, ineffective therapeutic regimen, but basically there will also a problem with ineffective tissue perfusion. What are the medical surgical management, oral intravenous management, supplemental oxygen implementation, assistive device, and cardiac transportation? So in your pharmacologic management, you may anticipate to have ACE or angiotensin converting enzyme inhibitors. The first line treatment, the ARBs, the second line treatment, and your diuretics, the loop or potassium sparing, beta blockers, anticoagulants, vasodilators, digoxin. Please memorize this because it really came out in the exams. Complementary and alternative medicines, hawthorn berries. So I'm not gonna tell that more. But the diet will always low sodium and fluid restriction. Remember that all of the heart problem, it should be a low sodium and fluid restriction and high diet, high fluid. I mean high fluid, high fiber food. Because if there will be a high intake of sodium, there will be a pressure of pooling of your water that becomes problem in the circulation. So you really need to lessen the sodium intake of your patient and fluid restriction also. Just like I have said a while ago, you have to improve cardiac output, improve gas exchange, restore fluid volume balance. So client education, low sodium diet, 2 to 3 grams per day. Vaccination, flu or pneumonia because it can have it. Aerobic exercise. Early signs and symptoms are SOB, orthopnea, and weight gain. Eating and digestive symptoms. Take enough calories and nutrients. Choosing foods easy to digest and to not force a person with heart failure to eat. Please. Next is these are the sample of nursing care plan. So living with HF is a challenge to sufferers of this condition. It also represents a significant burden for caregivers. Effective management of HF is achieved through medical optimal. Thank you so much for listening for another topic. Let's go directly to another one. I hope you are still listening and you are still with me. Okay, let's go. Let's go with your coronary artery. So we have coronary arterial disease. So this is a disease that delivers constant supply of the blood to heart muscle starts to develop fatty plaques, which leads to restriction of blood flow to the heart. What is it? Coronary arterial disease. So this is a diagram. This leads to restrictive blood supply to the heart muscle, which leads to chest pain. Again, stable and unstable angina, fatty plaques, coronary arteries of the heart, your aorta, all of the coronary arteries are possibly be destructed. So again, the risk factor smoking, family history of diabetes, and high cholesterol, heart, healthy artery, blocked artery. So these are just a simple diagram. Basically, because of the atherosclerosis accumulation. So risk factors, age, gender, ethnicity. It's actually Caucasians. Smoking, obesity, hypertension, high cholesterol levels, and sedentary. So, when you do the atherosclerosis, there will be a low inflammatory state, there are low progression, and a rapid progression. In the slow progression, there will be an intimal thickening and plaque buildup, while in rapid progression, asymptomatic or symptomatic. If this is symptomatic, it means occlusive thrombosis or plaque disruption erosion. But if it's asymptomatic, plaque occlusion and non-occlusive thrombosis. Again, for the rapid progression, plaque hemorrhage is positive. So complications for this, again, I have already talked about that acute coronary syndrome, but this is coronary atrial disease, okay? It's different. SCMI, it's a window maker. Non-SCMI, it's unstable angina and concern for cardiac arrest. Meaning, if Your patient is telling you that I cannot breathe and my heart is like it's like it's like having been stabbed. Then you did not see any STMI in your ECG. Please be cautious because that's the concern for cardiac arrest. Unlike with STMI, we can really see at the ECG. If you are suspecting with non-STMI elevation, MI, so again, what is that? You need to have blood work markers. I think I have told you about this one. It's just the same with acute, no? But this is nice because I have prepared this normal ECG tracing, but you can see the ST depression and the ST elevation. So this is an example of stress test, the heart catheters, and the medications, of course, the aspirin, the Plavix, no ASA, nitrates, or this is what you call the patch. That if your patient is really under with that, automatically you will patch it. In patching, okay, I have to tell you about this. In patching, you do not do not shave, do not wet the chest, but you have to wipe it and then make sure that you will put the patch in a very or in a lesser hairs, no, very important because the patch itself should be directly be put in the skin because it has nitroglycerin, and nitroglycerin dilates vessels to allow more blood to get to the heart muscle. So that means if you will put the nitroglycerin in a hairy part, it will alter the reason or the purpose of nitrates. And we also have sublingual. So, uh, what's more faster? It's the patch. But if you have IV, then go. What not to do? So, in nitrates, of course, do not give patient to take phosphatidylase inhibitors. What are these? Viagra, Levitra, and Cialis. How to take? Chest pain, 1 tab or spray under the tongue, repeat for 5 minutes, and if not relief, 3 doses, call 911. So in Lipitor, Zocor, and Grestor. So you need to remember these. These are the cholesterol medications. Lipitor, Zocor, and Grestor. Because these are the ones who will decrease the LDL, lowers LDL total cholesterol and triglyceride. The statins. This is what you call the statins. So in cholesterol medication, you have to notify the MD if it develops muscle pain and tenderness. You need to monitor the CPK level, causes the muscle problems, and the liver function. And note, does not replicate diet and exercise. In beta blockers for diabetic patients, make sure that they watch out for masking signs. And what is that? Hypoglycemia. Not prescribed for patients with history of COPD or asthma because it potentiates the causing of bronchospasm. LOL. All LOL is a beta blocker. Okay? Metoprolol. Not to take with grapefruit juice. Might it can alter the absorptions, lowers BP in HR, lowers workload on heart, and lowers episodes of the chest pain. So what is ACE inhibitors? The PRIL, all PRIL. Blocks the conversion of angiotensin 1 and angiotensin 2. It allows vasodilation to lower blood pressure, and it may develop nagging dry cough, which needs to be switched to something else. So you have to be alert. Surgical management, bypass surgery, beating heart surgery, and arrested heart surgery. This is stenting. You have to put stents inside. This is balloon angioplasty. You have to put the balloon. It's like a catheter that you need to inflate. In stenting, it's like a catheter also, but however, you will um you will leave the stent, not the balloon. In balloon angioplasty, you just need to uh, balloon, and then after the coronary artery has been elevated, then you can remove the balloon. In MICS cabbage, you really have to put something. It's the pacemaker. Now, the nursing diagnosis for this is acute pain. It really pains at really. So we need to decrease the myocardial blood flow. So this is example of the NCP. You might as well want to check. So thank you so much for, and also I'd like to thank for my former student Ardell Green for also helping me out for this a very nice PowerPoint. Thank you so much. So are you ready for another topic? We have to, jump over. I'd like to thank for the team Lamdag always helping me out, making my, making my PowerPoint very nice. Okay. For the next topic is cardiogenic. Okay. What is cardiogenic shock? Again, this is cardiogenic. Cardio is a heart. Genic is originating from shock. Inadequate tissue perfusion resulting in a decreased oxygen in the cellular level. So cardiogenic shock happens when a heart cannot pump enough blood to meet the perfusion needs of the body or the pump failure. Why does it occur? Filling, contraction, conduction, and structural defects. When it feels cannot fill with the blood normally, the diastolic dysfunction, heart failure. Contraction, it's a problem in getting the blood forward out of the heart, so that's a problem of systolic dysfunction. Conduction is an electrical system that controls the rate of the rhythm of the heartbeat. So that becomes arrhythmia and dysrhythmia. Structural defects, deviation from normal structure, and valvular diseases. So why does it occur? Of course, it is not due to loss of blood volume to pump. It is just not working. It cannot maintain cardiac output. So decrease cardiac output is equivalent to decrease of perfusion. So cardiac output is expressed in liters per minute. It's the amount of the blood that heart pumps in 1 minute and heart rate. So why does it occur? 4 to 8 liters per minute and increase CO equivalent to heart rate times the SV. Cardiac output equivalent with decrease of perfusion. So the stroke volume or the SV amount of the blood pumped by the left ventricle each beat. So stroke volume is we have these three words: the preload, afterload, and contractility. So in a preload, that's the ventricular stretches at the end of the diastole. After load, it's the pump against to squeeze out of the blood. In a contractility, how well the muscle cells constructs. Other possible causes: myocarditis, endocarditis. So when you say myocarditis, it's the muscle in your heart that inflames. Endocarditis, it's the infection of the heart valves. Weaken the heart from cause, drug dose, and poisoning. Cardiogenic shock occurs as a serious complication in 5% to 10% of the patients hospitalized with acute myocardial infarction. So historically, mortality of the cardiogenic shock had been 80% to 90%, but its recent studies, it has dropped to 56 to 67. So most common in men than in women. Classifications are coronary and non-coronary. When you do your coronary cardiogenic shock is more common than the non-coronary cardiogenic shock. It is seen most often with patients with acute myocardial infarction. Now, in non-coronary cardiogenic shock is related to conditions that stress the myocardium as well as condition that results in effective myocardial functions. So let's go with the pathophysiology. Thank you, Shani, for this. Okay, so it's quite small, but we have to, and it's too long. I have to make it more easier for you to understand. Um, Precipitating factor are usually the drug overdose, poisoning, and unhealthy lifestyle. The predisposing factor, gender, history for heart failure, existing cardiac problem, or old age. So if both of the precipitating or both of the factors has been manifested by your patient, usually myocardial injury or dysfunction occurs. So if this would happen, there will be systemic inflammation. So systemic inflammation, everything, no? It increase the cytokinase, the increase of inos, no peroxinin, and it decrease systemic perfusion. So in MI or myocardial injury or dysfunction, there will be also problem in systolic and diastolic. That is why nursing students or nurses should always check for the BP of your patient if your patient is manifesting cardiogenic shock. It in systole, there will be a decrease of cardiac output. So if there must be a decrease of cardiac output, there will be a decrease of stroke volume. If in diastolic, there will be a decrease of level P, and there will be a pulmonary congestion that leads to hypoxemia. Now, another way or knowing that your patient is undergoing with MI, lactic acid accumulation and fall in pH, metabolic acidosis occurs, then cell membrane dysfunction and failure of sodium pump. That intracellular lysosomes rela- release digestive enzymes and influx to sodium and water. So there are four ways actually going to your ischemia. All of it will go to your ischemia because of the compensatory vasoconstriction. Some of it are fluid retention, and some of it are decreasing of perfusion pressure. So if all of it comes to ischemia, there will be acute pulmonary edema, arrhythmias, and hypotension. So again, there is really no specific pathophysiology of a certain problem. It really you can really base it in the patient's condition and the the immediate manifestation of your patient. So you really need to understand how many ways to attack a problem. So that is why this is so nice because it has four ways to know that your patient is really dying, or shall we say it's not dying, having cardiogenic shock. So most of it you should always get ABG, X-ray, ECG, vital signs with BP, RR, and pulse. Then you have to hook your patient with cardiac monitor. Then you can really help. That's the nursing management or the nursing responsibilities. In cardiogenic shock post AMI, your left ventricle and diastolic pressure increases. So it decreases the stroke volume. Organs affected by cardiogenic shock, the brain, cardiovascular, skin, respiratory, and renal. So in your brain, there will be altered mental status. So you cannot really question your patient directly because there are problems, no? Cardiovascular, ischemia, tachycardia, hypotension, the skin, cold tummy, and delayed capillaries. So renal would be oliguria, excretion of low solute urine, and then dyspnea. What are the cardiac markers? The troponin and BNP. Always remember that if your patient is under with problem with the heart, you need to check the doctor's order if the doctor ordered troponin and BNP. Because troponin releases when there is injury to heart muscles. BNP releases the ventricle's heart cells due to strengthening from high blood volume in the ventricle. Okay? There is what you call cardiac markers. So, as a nurse, you may recommend your doctor, doc, would you like to have a cardiac markers? So, diagnostics. What are the diagnostics? Chest X-ray, of course. You will know if there will be a pulmonary edema or heart enlargement, and then do your ECG for God's sake immediately or baseline. And then after that, you may also echocardiogram. And then we also have atrial blood gas, your ABG, serum lactate, because cells switch from aerobic to anaerobic metabolism. So lactic acid accumulation is a result of switch. So another one is a formulation of lactic acid is actually part in your um, excessive excessive muscle usage. So, pamaol. So that's what we call accumulation of lactic acid. So please take care of your muscles. Cardiac catheterization. The test can reveal blocked or narrowed arteries used to diagnose and evaluate common heart and blood vessels problem. So how do we prevent? Of course, do not smoke, maintain healthy weight, eat less, limited added sugar and alcohol, exercise regularly. What are the treatment? Emergency life support, ACLS, your, if necessary, patient will be connected with breathing machine or a ventilator, then receive medications and fluid. Go for it. Vasodilators, nitroglycerin. Beta blockers, propranolol, 20 to 40 milligram. Calcium channel blockers, nifedipine, verapamil. These are the medications that really came out in the board exam. Thrombolytics, streptokinase, and urokinase. Just remember, antiplatelet medications. Aspirin to help prevent new clots from forming, diuretics, furosemide, inotropic agents, dopamine, and dobutamine. So, if you remember, I have said about inotropic agents, dopamine uses to increase the blood pressure, and dobutamine used to improve the cardiac output. So, you may have double line. I mean, double IV line or intravenous line. Norepinephrine can increase blood pressure successfully in patients who remain hypotensive. So in medical procedures, angioplasty and stenting is one way. So yeah, angioplasty and the stenting. And we also have intra-aortic balloon pump. And this is the example of coronary artery bypass graft. I have presented a while ago what is really, how does it um look like. But this is inside your heart, no? Coronary bypass surgery redirects the blood around the section or of a blocked and partially blocked artery in your heart. So your nursing management for this, if your patient is under cabbage, you always check for the vital signs. That's your nursing management only. Check for the BP, check for the pulse, and check for the heart rate and auto saturation. That is why you need to hook your patient into a cardiac monitor. In heart transplant, of course, there's an operation which is deceased and failing heart is replaced with a healthier donor. So it should be fresh. Ventricular assistive disease. So this is what we call implantable mechanical pump. This is what you call the pacemakers. When you say ventricular assistive device, this is the one who pumps the blood from the lower chambers of your heart to the rest of your body because you can see these attachments automatically. So try to check your patients if they have these devices. So what are their nursing interventions? Identify the patient risk. Again, assess for the early signs and symptoms. Check for the BP. the HR, and urine output is very important also because urine output, your kidney, can filter the blood flow. Circulation can also go to your urine, and if there will be no urine output, it means that there are problems with your heart also because it happens with congestive heart diseases. What are the nursing diagnoses? Decreased cardiac output, impaired gas exchange, ineffective tissue perfusion, anxiety related to intensive care, impaired physical mobility, because of course, if your patient is under cardiogenic shock, please do not let your patient go to scuba diving, run, mountaineering. They cannot do that anymore. So if you want to answer, case study for this, and this is the answer. It's a practice case study. You may also have reference to your duties. So thank you so much. Thank you so much for my students before for helping me out, Shani. And to my students right now, thank you so much for listening. Another topic. I hope you're still there. Okay, let's go to cardiac arrest na. Okay. Okay. Wait for a while. Okay. I hope you can see the presentation. So what is cardiac arrest? Cardiac arrest is when your heart suddenly stops pumping blood around your body and when your heart stops pumping blood in your brain and starve for oxygen. So why does it occur? This is disease heart's electrical system malfunctions. So malfunction causes abnormal heart rhythm. Cardiac arrest is when the heart stops beating abruptly and either malfunction in heart's electrical. So heart attack is a blockage or narrowing of the coronary artery, cuts off and reduces blood flow of your heart and causing damage due to lack of oxygen. Oh my gosh. So two types of rhythms of cardiac arrest. Shockable, rhythms that are caused by aberration in the electrical conduction system, pulseless ventricular tachycardia or ventricular fibrillation. Remember, I have told you when are you going to use your defibrillator? Pulseless ventricular tachycardia and ventricular fibrillation. Non-shockable are rhythms that are amenable to shock, includes pulseless electrical activity or asystole. So causes of cardiac output, ischemic heart disease, cardiomyopathy, valvular abnormalities, primary cardiac arrhythmias. Non-cardiac causes of cardiopulmonary arrest, pulmonary aortic dissection, intoxication, hypovolemia, electrolytes, neurologic sepsis, accidental hypothermia, and other known. So there are four H and four T's: hypoxemia, hypovolemia, hyper and hypokalemia, and metabolic disorders. That you have to remember that your patient will have cardiac arrest. Arrest means patay. 40s, tension, pneumothorax, tamponade, toxins, poisons, and drugs. What are the risk factors? Predisposing factors are age, normally. Previous episode of cardiac arrest, personal family history. So please do not take for granted if you have seen those kind of history before. The precipitating factors: smoking, blood pressure, cholesterol high, obesity, diabetes, and inactive lifestyle, using illegal drugs, cocaine and amphetamines, nutrition balance such as low potassium and magnesium levels, obstructive sleep apnea, and chronic kidney disease. Okay. Cardiac arrest, irrespective of initiating rhythm, inadequate delivery of oxygenated blood to the tissue, activation of the number of mechanism, systemic inflammation response of irreversible damage, then there will be an activation of various biochemical pathway. Since there is a three phases, electric phase, circulatory phase, and metabolic phase. These three will undergo the tissue injury. Okay? So, pwede electric, pwede circulatory, and pwede po metabolic phase. Tanan na tissue injury. So, what happened if your tissue has been injured? Local ischemia, global ischemia, and reperfusion. So, again, local, of course, some of the area, global systemic reperfusion is every perfusion of your tissue has been damaged. So, it changes the logical effects and similar to systemic sepsis. So, if it happens, it results organ system damage or post cardiac syndrome. So, in post cardiac syndrome, there will be post-cardiac brain injury. There will be post-myocardial dysfunction and systemic ischemia reperfusion response. So meaning your patient really um, will not go directly to the cardiac arrest. But there's also a process that you will know that your patient is really dying and will be dead, will die. So signs and symptoms. Chest pain or discomfort, shortness of breathing, weakness, unexplained wheezing, rapid, irregular, fast breathing, fluttering, bounding heart. Common cardiac arrest, sudden collapse, no pulse, no breathing, loss of conscious. So, conduct CPR. So, electrocardiogram, imaging, provocation, and discrimination. Provocation is a brugada, epinephrine, long QTV, and exercise test. Discretionary is electrophysiology study, cardiac biopsy, and genetic testing. So diagnostics, those are diagnostics for cardiac arrest. So how do you prevent? Of course, the chain of prevention. Chain of survival. Early recognition, call for help to prevent cardiac arrest, early CPR, early defibrillation, and post-resuscitation care. Early assess, CPR, early defibrillation, early ACLS, and early post-resuscitative care. So what are the treatments? CPR, of course, I know you know already. Defibrillation, ventricular fibrillation, a type of arrhythmia that can cause sudden cardiac arrest. So that's the ACLS. Long term, after your treatment, doctor will discuss with you, your family, that other tests might help determine the cause of a cardiac arrest. So medications, lidocaine, epinephrine, atropine, and Narcan. Lian. Remember the Lian, okay? In medications for cardiac arrest. Lidocaine, epinephrine, atropine, and Narcan. So other medications for during cardiac arrest, adrenaline, amiodarone, calcium chloride, magnesium sulfate, additional drugs, and miscellaneous drugs. So there are implantable cardioverters and coronary angioplasty. I think I have said it in other problems of the heart. Coronary bypass, radio frequency catheter. This is a guides a tube into your heart to destroy small areas for tissue. So it's a high equipment, no. Radio frequency catheter lang. So direct then insert ang needle. So what are the nursing diagnoses? Acute pain related to tissue ischemia as evidence as chest pain, risk for decreased cardiac output, risk for ineffective tissue, risk for ineffective breathing pattern. If those are things that are problem, then it's ineffective tissue problem, ineffective tissue perfusion, ineffective breathing pattern. So nursing intervention for shockable, perform CPR and monitor cardiac rhythm. Give 1 milligram epinephrine with an IV or endotracheal tube. So if you notice, I have presented ACLS or the mega code. So these are the things that they did. Repeat for 3 to 5 minutes. You can also give vasopressin, 40 units, but one time only. Continue CPR and medications until cardiac rhythm returns. For non-shockable sudden cardiac arrest, begin CPR using basic life support interventions immediately. Compressions must at least 100 per minute and consistently fast and depress 2 to 0.4 inches. Airway must be placed to deliver oxygen. Insert IV, IO, or intraosseous to give immediate access to the bone, and epinephrine is drug for choice of PEA and acetylate. Use 1 milligram every 3 to 5 minutes and then locate the cause of event. So if might as well you want to answer the case study. So this is the nursing care plan that you might have reference to your NCPs in your duties. So external hemorrhage. What is external hemorrhage? Bleeding happens when blood exists through break in the skin. Blood loss from bleeding tissue and can also be apparent when blood exists through natural opening in the body. So internal and versus external. Internal, of course, inside. External, outside. There's nothing to remember. If you notice, there's no blood. Here, there's a blood outside. Types of external hemorrhage: capillary bleeding, venous bleeding, and arterial. Okay, capillary bleeding is a slow and oozing, easily controlled, stop spontaneous. Pag venous bleeding, steady flow, easier to control, and low pressure system. Pag arterial bleeding, rapid and profuse spurting with heartbeat, most difficult to control. You need to know what are the external hemorrhage. So, what are the common injury? Abrasions. Abrasions is a scrapes that don't penetrate too far below the skin. Lacerations is the cuts. So, from now on, please use scrapes. Do not use scrapes and cuts already. So, abrasions, lacerations, puncture wounds from items like needles, nails, and knives, crushing injuries, gunshot wounds. In common conditions, we have hemophilia, menorrhagia, thrombocytopenia, and von Willebrand disease or vitamin K deficiency. It came out in the board exam. What are the common problems, I mean, common conditions in external hemorrhage? What are the risk factors? Trauma, injury, surgery, invasive, medications, anticoagulants, and some herbal remedies. So, pathophysiology, of course, external hemorrhage, trauma, tissue damage, hemorrhage. Yun lang. Signs and symptoms: bruising, discoloration of the skin, pale, pain from the skin surface, loss of normal function, and wound. Signs of medical emergency: bleeding caused by serious injury. Bleeding can't be controlled. The person has gone into shock or has fever. So you have to memorize those things. Medicines: aspirin and other NSAIDs, antibiotic when used on long terms, blood thinners. Intervention, first aid. I know, I'm very glad that you have done your first aid. Apply direct pressure, raise injury, and foreign bodies. Keep the patient total rest and seek medical assistance. So nursing diagnosis: acute pain, bleeding, bleeding, bleeding. Might as well you want to know the case study and then answer. Thank you so much for this is for cardiac arrest and hemorrhage. For the last topic, for the last topic, for the for the for the shakabul. Okay, for the last topic, this is heart related and submersion injury. Okay. Heat emergencies are health crises caused by exposure to hot weather and sun. So there are heat cramps, heat exhaustion, heat stroke. Symptoms: heat cramps, muscle pain, tightness, normal body temperature, and cool, moist skin. Muscle cramps, dizziness, mild confusion, fast heart breathing. So those are the things, if you remember during your parade, yeah, those are just heat exhaustion. We'll not talk about it because it's quite too long. Potential complications for heat emergencies. Most people recover from any of the stage emergencies in heat views. So vital organs like your brain may begin to swell during heat stroke. How can heat emergency be prevented? Of course, ventilation, air conditioning. Rest as often as possible. Wear light colored, loose clothing. Drink water. Avoid alcohol. Yun lang. Heat stress, cold sick, evaporation. You just need to let your patient in a well-ventilated area. Yun. Medical interventions, call 911, emergency room. Don't give any persons anything to drink if they are vomiting unconscious. Never offer a drink containing alcohol or caffeine. Heat cramps. Step one, move to a cooler area. Gently massage the cramping muscle. Stretch the muscle gently, then drink cool water or sports every 15 minutes. Heat exhaustion. Move to cooler area, loosen clothing, apply cool wet towels, then and have someone fan your skin. So these are the things that you also remember for being a responder. Okay. Step five, drink cool water. Don't drink too quick. Heat stroke. Move the person cooler, loosen clothing, remove sweaty, and apply cool wet. Apply ice if you have it, and then underarms. Pharmacological benzodiazepines. These are just, I know it's anxiolytics, but it is really the medication because it affects the controlling agitation conversations. Observe IV site closely, monitor adverse effect. Sodium bicarbonate, it's alkalizing agents that indicate for severe acidosis and rhabdomyolysis. Useful alkalination urine, it may be administered as bolus. Oh, there's in consideration for bowel movements. Mannitol is very important in exhaustions because your information will utilize in the making reabsorption. Mannitol is a drug for choice for forced diuresis in patients with rhabdomyolysis patient because of the number of beneficial effects on the kidneys. So, nursing consideration, cause phlebitis at AV site may cause dehydration, fluid, electrolyte, monitor neurostatus, and emitter via filter. Dobutamine. Dobutamine is a synthetic compound structurally similar to atecolamines. It is the drug of choice for circulatory support. Nursing consideration, IV site, of course. Adverse effect. Then check RLI and PRN. Monitor fluid balance. Submersion injuries. What is this? These are drowning or near drowning or a serious threat to the life or health children. So difficulty in breathing, hypothermia, which occur with warm or cold water, abnormal heart rate, loss of consciousness. Submersion is perceived risk for drowning, loss inhalation effort, and moment of submersion, then tissue perforation, hypoxia, acidosis, and hypercapnia. Then there will be a laryngospasm, aspiration, loss of consciousness, and then involuntary respiratory drug and respiratory failure of death. So, meaning if your patient, if you know that there is drowning, dili na diretso mamatay. There are process. That is why being a nurse or being a responder, you have to respond quickly. What are the preventions? Airway, make sure the airways are clear. Breathing, make sure the person is breathing. Circulation, make sure the person has pulse. The person is not breathing and does not have pulse, do the CPR. So we have to prevent, of course, for those parents, for those you will be assigned in watery area. Cold-induced bronchoria, manage this aggressively. Albuterol is preventable. Rux bronchial smooth muscle, so you can give it for bronchospasm. Minimal doses for minimal periods. And yeah, you need to remember these nursing considerations. Use minimal doses for minimal periods. Drug tolerance can occur with prolonged use. Maintain a adrenergic blocker as ethanol and should be used in respiratory disease. Prepare solution for inhalation. Do not exceed recommended dosage and report chest pain, dizziness, insomnia. So those are the last thing that you really need to remember for injuries. Thank you for listening. I hope you've learned something from day one that I have been talking and been sharing my knowledge. Thank you for being a nice students for me, and I hope you learned something and you will really apply it. And good luck and God bless registered nurses.